Thank you, sir. First of all, I really thanks Dr. Vitul Gupta ji for excellent hospitality. We enjoyed, and definitely the Punjab is the great personal leaders, and the hospitality of Punjab is really great. So thank you very much for inviting me, and my best wishes from not only from me also, but from the Bihar as well. So my topic is the ADA 225 standard of care. What's new? If you can see the field of diabetes, not only diabetes, all science is ever changing. So we need regular updation, or really you can say for the diabetes is concerned, we need a yearly updation. So, and the American Diabetic Association has long been a leader in producing guidelines since 1989. That's what. And the 225 standard of care in diabetes has continues to incorporate person first and inclusive language. Many societies have endorsed different sections in the ADA, this standard of care. There are 17 sections in this particular SOC, and different sections will be endorsed by the different society. Like the section 4 by the Bone and Mineral Research Society, American Society for Bone and Mineral Research, the section 8 obesity and weight management by the Obesity Society, and similarly the section 10 by the American College of Cardiology, and section 13 by the American College of American Geriatric Society. There are many changes, but what is important I incorporated in this particular section. So I will go by the section by section, and if you can see the first section, the improving care and promoting health in a population, we can see that initially it was that the people of diabetics should be advised to take lifestyle modification and other things. But now this is expanded to include the people at risk of diabetes. So people at risk of the diabetes should be started with the lifestyle modification. Just Dr. Rajesh Aggarwal has said the pre-diabetic patient should be having this lifestyle modification and the treatment possibility. So this is the new changes that the people at risk should be incorporated. And second is the chronic care model. The patient-centered approach must be there, and every patient is different, so a patient-centric medical home model should be applied. So patients should be educated to take care of themselves, so self-management schemes should be instituted. And there are other emphasis has been the importance of addressing disparity in the diabetes care and health outcome. You can see the different sections of the society are not accessible to the different type of care in the society. So this thing is incorporated in this subsection. In sections second, the diagnosis and classification of diabetes, there is table 2.3 was added to provide consideration related to the use of and interpretation of the laboratory management of the glucose A1C. You can see that if the glucose parameter is there, you say in different lab, the blood glucose, plasma glucose or capillary glucose, there are different levels will be there. If you can test the whole glucose, the level will be there different. If you use plasma glucose, the level will be there. If you use capillary glucose, the level will be less. So there are some problems with the blood glucose monitoring, and similarly with the A1C measurement also, because A1C measurement should be endorsed by the different international guidelines standard. So there are certain things which to be included, and this table 2 is incorporated in that. In blood sugar test, if the blood sugar will be stored in more than 1 hour or 2 hours, so that there will be changes in the parameter, so you have to use this A1C level or the blood glucose level, what you want to say, it depends upon the different situation. So in blood sugar level, you use fasting and postprandial, and similarly in HbA1c, you any time in blood sugar can be blood test to be instituted. So these are the criteria. The second recommendation is that in the importance of antibody-based screening for pre-symptomatic type 1 diabetes in individual with a family history of type 1. You all know there is a 3 stages of type 1 diabetes mellitus. The non-symptomatic patients of type 1 diabetes should be screened for in the patient with a family history of type 1 diabetes or otherwise known elevated genetic risk. Why this test is important, I will say in next slide. And the classification substation, there is provide a pragmatic approach to the management of the individual who have a feature of both type 1 and type 2 diabetes. In section the prevention or delay of diabetes and associated comorbidity, the life behavior changes of the type 2 diabetes prevention subsection. Sleep health is the very important. You all know that in the lifestyle modification, diet, second is your exercises, third is the mental yogas and mental relaxation phase, but fourth is the sleep. Sleep is a central component in the management of pre-diabetes and diabetes, placing it other form of the lifestyle modification, because you need 6 to 8 hours sleep daily. If you see that the mobile application is increased in the younger generation, and it is one of the reasons that the type 2 diabetes mellitus is increasing in the younger population in our part of the world also. Similarly, there is a recommendation that the patient having aged 8 years or more with stage 2 type 1 diabetes, the role of teplizumab infusion to delay the onset of symptomatic type 1 diabetes mellitus. So the screening of the type 1 diabetes mellitus at the stage of pre-symptomatic level should be there. In comprehensive medical evaluation and assessment comorbidity, dental care should be instituted. The new subsection is added, and dental examination is must every once in a year. A new subsection of female sex dysfunction was added, and the healthcare professionals should inquire about the sexual health, particularly in women who experienced depression and or anxiety and those with the recurrent UTI. So the female sex is come in this particular subsection, and that is added in new. And the nomenclature of the NFLD or NS was updated to metabolic dysfunction associated steatotic liver disease and metabolic dysfunction associated steatohepatitis respectively. And one new concept amended to the state that the patient having this MAS or the MSLD, the FIV score is the one of the very important parameter you can judge even in clinical practice. If it is more than 1.3, should be additional risk stratification performed. So FIV score is one of the best method. And second in the treatment module is the thyroid hormone receptor B agonist in adult with the type 2 diabetes mellitus or pre-diabetes with MASLD with moderate or advanced liver fibrosis may be considered. You all know that the thyroid hormone receptor B agonist is already been in market in America as an resmetirom. In facilitating positive health behavior and well-being of the patient, the diabetes self-medical education support subsection is added, and it has emphasized that all people with diabetes should be advised to participate in this diabetes self-management education program. Initially it was that the patient should encourage to participate, but now it has been incorporated that all patients of the diabetes should be advised to participate in this diabetes self-management program. And we have to do the diabetes with the fast, like the Ramadan International Alliance. Comprehensive pre-fasting reassessment is must to stratify the people with diabetes prior to engaging the fast stage. And use of recreational cannabis should be avoided in all patients who are at risk of diabetic ketoacidosis because it is a higher chance of cannabis hyperemesis syndrome. So the use of recreational cannabis should be avoided, should be banned. In glycemic goal, the new subsection is the hyperglycemic crisis, diagnosis, management and prevention was added. There is a routine assessment of history of DK and HS and provided a structured prevention education in the outpatient setting. Means the DK and HHS, which has been incorporated in only the in-hospital patient, should be screened or structured in outpatient settings. Technology, there is a considerable advancement in the diabetes technology, and you all know that the CGM, use of adult with type 2 diabetes on glucose-rearing agent other than the insulin. Those who are insulin, you can advise the CGM, but even in those on the oral hypoglycemic agent can be used CGM for the better control of the glycemia. And similarly, the management of diabetes in pregnancy and reflect that update CGM can be used in pregnancy also, whether not only in the type 1 diabetes but also in the type 2 diabetes as well. In obesity and weight management, there is a guideline addressing weight management pharmacotherapy beyond the goal of simply lowering blood sugar, emphasizing the importance of the addressing other aspect of the metabolic health is the all. Our patients should not only be advised to reduce their weight, but also to advise that maintain their reduced weight as well. Pharmacological approach to glycemic treatment, section 9, beyond weight loss, GLP-1 receptor agonists are now recognized for their benefit in the heart and kidney health also. The use of GLP-1 are with demonstrated benefit in individuals with type 2 diabetes, symptomatic heart failure with preserved erection and obesity also. And the recommendation was revised to recommend use of either SGLT inhibitors or GLP-1 receptor agonists with demonstrable benefit in individuals with type 2 diabetes and CKD. Means the GLP-1 receptor agonist can not only be used in diabetic patient but also in the CKD patient. And it has also been recommended that this GLP-1 receptor and pioglitazone or combination of GLP receptor 1 agonist and pioglitazone can be used in different stages of MA, SLD and MAS. In cardiovascular disease and risk management section, then recommendation 10.26 as added to recommend that in most cases lipid lowering agents should be discontinued prior to conception, avoided in sexually active individual of childbearing potential, not using reliable contraception unless the benefit may outweigh the risk. So that in the patient, female patient, we are in childbearing age, so this lipid lowering agent should be cautiously used and that should be individualized. And reduce complication, there is a glycemic management, BP management, lipid management and use agent like the CPN, kidney benefit, GLP-1 receptor and SGLT2 inhibitor. In chronic kidney disease, as I have already said, that the GLP-1 receptor with demonstrated benefit in the population should be used to reduce cardiovascular as well as the kidney disease progression. So GLP-1 receptor agonist has come in big way in the management of diabetes. And this recommendation 11.6 was added to state that the potentially harmful antihypertensive medication in pregnancy should be avoided in sexually active individual of childbearing potential, not using reliable contraception, or to switch to the option considered safer prior to the conception and during pregnancy. So in pregnancy, you use the drugs in pregnancy or the patient having a childbearing age, you use the safer drug so that if accidental pregnancy may happen, so that should be the complication could be avoided. In retinopathy, neuropathy, nothing more important, but the retinal examination must be frequent to rule out the diabetic retinopathy. And similarly, you can use your hand as an screening for this diabetic neuropathy, because if you have not having monofilament, don't worry, you have to use your fingertip as an Ipswich test as an option for the neurological assessment. In older patient, there is the older patient having the many cognitive disorders, and they may have dependence upon the other person for their livelihood. So you have to be very friendly and health system, that is a medication, mobility, and what's matter most as it applies to diagnostic management in older patient. And the recommendations are modified to include time in range, time below range, in addition to A1 treatment goal for older agents who are otherwise healthy and pure and stable chronic condition and intact cognitive functional disorder. In children and adolescents, the recommendation has changed to state that the insulin pump should be offered to anyone with type 1 diabetes who can use device very safely. Initially, in children, the insulin pump should be avoided, but now it is recommended that the children, if he can understand or he can use the device safely, can be used this insulin pump. And the new terminology from the hyperglycemia, hyperosmolar non-ketotic syndrome has changed to the hyperglycemic hypersmolar state, and includes the intravenous fluid as an initial step to treat severe hypoglycemia once the diagnosis is concerned. And the management of diabetes in pregnancy, we have already said that whether you are using the term gestational diabetes mellitus, management of pre-existing type 1 diabetes or type 2 diabetes, the treatment is more or less same, either insulin or you can use some metformin or other drug, but the treatment is same. So they have merged our one new section and management of diabetes in pregnancy. That's all. Nothing like gestational diabetes mellitus, pre-existing type 1 diabetes mellitus or type 2 mellitus, all incorporated in management of diabetes. I think it's a good approach. Why we should use gestational diabetes mellitus, why you should use, the treatment is the more or less same. So which includes all aspects of management of all type of diabetes, nutritional, physical activity and pharmacotherapy. And the recommendation new longer state the CGM. In pregnancy also CGM can be used. Initially it was not prescribed in the case of pregnancy, but now it can be used. The new recommendation now state that the CGM may be used in conjunction with blood glucose monitoring to achieve the glycemic load. So CGM comes in very good way, and GLP-1 receptor agonist has come again as a not only in the treatment of cardiac comorbidity, cardiac condition, but also in the CKD patients also. Diabetic care in hospital setting is a very important part, and you can see that in hospital the critically ill patient and non-critically ill patient. In critically ill patient, the diagnostic glycemic goal has been set to 140 to 140. Less stringent is recommended for most critically individual, but more stringent individualized glycemic may be appropriate if they can be achieved without significant hypoglycemia. The one factor is, limiting factor is the hypoglycemia. So hypoglycemia should be avoided, and in the patient with a most non-critically ill patient, the glycemic goal is 100 to 180 milligram per dl. So for the critically ill, it is 140 to 180, but if it is non-critically ill, it is 100 to 180. The diabetic advocacy, the subsection of diabetes care in school setting, and diabetes and driving. This is very important when you are a diabetic patient, you are traveling from one place to other place. So there must be some criteria. So they were updated with the information from the published advocacy statement and the sub-center of diabetes management detention facilities. The patient who are in the prison or who are in the detention center, so there must be some management criteria for the treating the patient of diabetes in that particular group. This is all about this section. The new update as per to conclude the factor is that in type 1 diabetes, antibody based screening is must in pre-symptomatic to symptomatic patient, because type 1 diabetes are used islet auto-antibody test and criteria for preclinical stage to type 1 to look for potential to delay the onset of using teplizumab in all the first degree relative of the type 1 diabetes, newly diagnosed patient, and based on the consensus guideline. And autoimmune disease screening is in type 2 diabetes, thyroid and celiac disease, and new screening, new recommendation, the person of DKA or the person at risk of DKA, avoid cannabis, recreational cannabis. So this is all about the screening of, we have already discussed the male and female sex health, psychological disease, fasting, and general how to screen the patient. This all about the ADA, a new recommendation, new SOC for this patient. Thank you very much for your patient hearing.